Hello everyone. I'm Dr. Abhishek Nighot. I'm a hip and knee arthroplasty surgeon based in Mumbai. Alongside clinical practice, I also have a strong interest in academics, teaching, and research. That's why we bring to you Arthroplasty TV under the aegis of OrthoTV. Arthroplasty TV is a focused educational platform created to share practical arthroplasty knowledge through conversations with experienced surgeons from across the world. The aim is to discuss decision making, surgical philosophy, and real world lessons that help surgeons improve their clinical practice. This platform is especially designed for residents, fellows, and early career arthroplasty surgeons. Through Arthroplasty TV, we hope to bring global perspectives closer to everyday practice. Arthroplasty TV is a focused educational platform catered to arthroplasty, and our Masterclass segment is especially created to share practical arthroplasty knowledge through conversations with eminent and experienced arthroplasty surgeons across the world. Through this, we hope to bring global perspective to everyday practice. And today, we have the pleasure of having a leader in arthroplasty, Dr. Neil Sheth, with us for the inaugural session of the Arthroplasty TV Masterclass. Dr. Sheth is the chief of orthopedic surgery at Pennsylvania Hospital. He's a globally respected surgeon in primary and revision joint replacement. He's known for his work in revision hip surgery and, of course, his commitment to training the next generation of arthroplasty surgeons. Dr. Sheth, we are delighted to have you with us today on Arthroplasty TV. To begin with, could you perhaps take us through your journey in hip and knee arthroplasty and your key influences or key mentors that shaped your approach along the way?
Yeah, Abhishek, thank you so much for having me, and it's a true honor to be a part of this. And as we were discussing previously, I think this is an amazing effort on your part and on the part of I think the young surgeons in India who are starting out their career in arthroplasty. So I'm really excited to be a part of this and looking forward to our discussion. I started out at the university. I was a biomedical engineering and finance major at the University of Pennsylvania, and I did not know I wanted to go into medicine. And our first year of undergraduate school, we had to take a class in the Introduction to Biomedical Engineering. And they put you on a team of 6 or 7 different students, and you had to come up with a problem in medicine that you can solve with engineering. And so we decided as a group to try to come up with how you can create an artificial kidney because all these people were getting dialysis. And the whole point was, I think, from Penn was that we don't know anything about anything in engineering, but let's see what you intuitively think you need to incorporate. And then we were going to go through school for 4 years, and now you have a senior thesis design project at the end in order to graduate. But now we've taught you all these tools. Now can you come up with some other solution to something? But part of this was spending time with kids at the Children's Hospital of Philadelphia who were on dialysis 2 or 3 times a week. And I sat there hanging out with them playing video games, and I realized that I probably liked the patient interaction more than anything else. And that's what made me decide to go into medicine. And then fast forward 1 year when I was a sophomore, so this is back in the mid 90s, we took our final exam in biomechanics. And in the mid 90s, there was not a great textbook for biomechanics. So we were really learning more from civil engineering textbooks and mechanical engineering textbooks. But the question that we got on our final exam was, you're an orthopedic surgeon and you have this patient who jumped off of a ski jump and landed at this this distance, this speed, landed, and they broke their tibia. And they got surgery, they got it fixed, and they're about 11 months out from surgery now. They're 95% strength. And in a month from now, this guy's going to go back and wants to go back to ski jumping professionally. And so, as an orthopedic surgeon, you've been asked to join a research design team to design a ski so that when he jumps from this height and this speed and this distance and all this stuff, he doesn't break his leg again.
Right.
And I think right then I had an epiphany moment to say, oh my God, like I think this is what I want to do. And so that was the first thing that really kind of geared me towards orthopedics. Um, Fast forward a couple more years, now I'm finishing up college. And at that time, since I had already done some finance and most of my friends were really heading towards Wall Street, but I really liked finance as well. So I decided to go to Wall Street for 3 years to learn a little bit more about healthcare business before becoming a physician. And I would say at this point in my career, looking back, that was probably the smartest decision I made because I learned a different language and I look at healthcare very differently than my colleagues here in the United States. So I spent 3 years there and then came back, went to medical school, still with the idea of wanting to be an orthopedic surgeon. And then I had the real pleasure and honor of training with Charles Nelson, who's my senior partner now, but was probably one of my biggest influences early in my career to consider arthroplasty. And I think, Abhishek, you know this, but I came to Penn to be a tumor surgeon. But
Hmm.
I had just finished Dr. Nelson's service, and I said, wow, this guy's doing these huge reconstructions. And I noticed that his ability to reconstruct these big defects was more impressive than I think what the tumor guys could do, where they were great at taking the tumor out, but then the reconstruction was almost an afterthought. And so I decided at that point early in my residency to do arthroplasty. And then I was fortunate enough to meet Craig Della Valle as a third-year resident and interviewed out at Rush and got my fellowship 3 years early. So it was already secured and locked in. And then, as you know, the rest, I mean, I came to Rush as a fellow. I had, tremendous mentorship there from Wayne Poprosky and Rich Berger and Josh Jacobs, Aaron Rosenberg. I mean, a whole crew of people that really taught me so much on how to think about things. And then I came back to Penn back in 2012. So now starting out my 14th year back here at Penn.
Right, and rightly carrying forward the legacy by teaching young arthroplasty surgeons, because you have a way of dealing with young arthroplasty surgeons, your fellows, your residents, which is unique because I've spent some time with you, and I know you do things a little differently. So, hoping to get into that insight a little bit.
Sure.
One thing I want to ask you is, moving into your day-to-day arthroplasty practice, what do you think are one of the are the most common technical or decision-making errors that you see surgeons do, and how do you avoid them?
So I'm going to break this into two phases. And I think, Abhishek, you and I have definitely had conversations about this, but I have conversations about this with our current fellows, our residents, medical students, even younger students, just to think about their training in sort of a certain way. So the two phases I think of is sort of while you're in training and then once you're out of training.
Hmm.
So I think in training, there's so much focus that is placed on the intraoperative phase of care. Everyone is interested in going to the operating room and doing cases, and I get it. I was the same as a resident or as a fellow. And then as you start gaining more experience, and especially after you come through fellowship and you get into practice, you realize that the other two phases that are actually critical, right? The preoperative phase, if you can't indicate patients properly, you're going to be miserable because patients are not going to do well. You're not doing the right surgery. And then that's going to impact their postoperative phase where patients are not happy and now you have other things to deal with. The second thing is the postoperative phase of recognizing when there's a complication. What can you treat non-operatively? What can you treat conservatively? What is something that's more emergent that has to go back to the operating room? Which patient do you need to see every week for the next 6 weeks versus I can see this person in 3 months or a year or whatever it is. So I think in the training phase, it's really important and it's very hard because this is such delayed gratification. And I think especially in India, for certain, where you have long terms of training, you start at a younger age, and then you get to that point of you want to be able to start doing surgeries, but there's not enough time spent on those other phases to supplement the intraoperative, right? If you can't do those other two phases right, the intraoperative phase is terrible. And then patients have way more problems, which really makes your life much more difficult to take care of those people. That's the first thing I'll say. The second thing is, I think in the early career surgeon, one of the things that I worry about is there's so many things that are happening simultaneously and so many things that are being brought out into orthopedics every year.
Yeah.
And I think that early surgeons have this pressure on them to change so many variables at the same time in order to try to differentiate themselves or create a niche for themselves in their market, wherever it is on the globe. And I think in the early part, when you start, you need to do what you were trained to do and perfect that. And it takes some time, somewhere between 2 and 5 years on any specific technique before you can evaluate that technique and say, this is not so good. My patients are not doing as well as my mentor's patients were doing this technique. Maybe I'm doing something wrong, or maybe I can't reproducibly do this. So I
Mhm.
need to change one variable to make this better and more reproducible for myself and for my patients. And in that phase, if you're changing too many variables and you're not hypercritical about every little change that you make, it
Mhm.
is very hard to get to a level where you say, I can reproducibly do this operation, right, for this specific diagnosis and for most of the patients that I see. So I think young surgeons may fall into the trap of trying to change too much at once. You need to get comfortable, change one variable at a time, and see what that variable has done for you, what that change has brought about for you, how your patients are doing as a result of that, and then go on to change something else. And I think changing things is important over time. You don't want to become stagnant. Don't do the same thing for the next 30 years. But change has to come slowly and it can't come all at once.
Right. You said change is important, but for somebody who's at my age, who's
Mm.
trained in, let's talk about alignment,
Mhm.
who's trained in one alignment philosophy. And when I see so many talks and so many different approaches to alignment these days, you sort of feel like the other alignment philosophy is a little alluring. How does one tackle that? How do you get from training one thing, but then looking at the other thing and feeling like maybe this is the way to go, especially with mechanical and kinematic alignment philosophies?
Yeah, I actually made this comment, I think, at the Indian Arthroplasty Association 2 years ago in an audience full of 1,000 people. And they had a panel of 9 surgeons up there talking about how they do a total knee replacement. And it
Hmm.
was great for me to hear them because 9 people are doing 9 different operations. Everyone's doing an anterior approach to the knee. Once they get there, they're doing a different operation. And I made the comment, I was like, for the trainees and the young surgeons in the room, I said, I feel badly because when I trained, basically, you had CR versus PS. You
Yeah,
maybe had measured resection versus gap balancing. If you got really fancy, it was anterior versus posterior referencing, but everything was straight,
yeah,
right? It was much easier to learn, and it was still hard to learn at that point to put those principles together.
right.
And now there's 15 different ways to do a total knee replacement, right? So many different alignment philosophies and bearing surfaces and so many different techniques and no release and little release and inverse this and that. And it's very hard. And this is exactly what I'm talking about, right? It's hard, I think, in your stage to come out and say, I've been trained to think this way for up until this point, and now there's all these things that are out. My suggestion would be is start with what you know that you've been trained on and what we know has long-term track record, right? We know that this is done properly is going to work.
Hmm.
Then you can start being, I think, cerebral about the fact is like, hey, listen, I'm doing a lot more work in reading and studying and actually observing some patients that have been trained, excuse me, have been treated by a different type of philosophy and say, let me start incorporating that into my practice. But maybe again, in that preoperative phase, selecting the patient properly, right?
Hmm.
Which patient may be best for this alternative alignment strategy? Maybe it's not for everyone.
Right.
Don't pick the fixed valgus knee with a 25-degree full flexion contractor for your first kinematically aligned knee, right? But the patient who's got CPAC 1, not terrible deformity, let me try this on this, right? And then you have to look at that patient. When they come back to the office, are they presenting differently and say, wow, this patient is coming back with less pain, less swelling. They've got better range of motion at 2 weeks or 4 weeks after surgery. Maybe this is the right thing for this patient. But then slowly, after you have some understanding of that and you see how your patients are doing with that change, then you can start expanding a little bit more, right? So I don't think, again, I think I would use the same philosophy of just trying to start slowly and
Mhm.
see if you can pick out those patients that you think would be better, right, for this technique over something else. Um,
Makes
because
sense.
if you make a huge change in everyone globally and say everyone's getting kinematic alignment now, you may not have the ability to actually evaluate the result or the effect of that change that you've made because it's everybody now, right? You want to be able to have smaller groups within what you do, right? I'm not interested in what everyone else does, but if in your practice you're looking and say, wow, these patients are doing better than my standard patients the way that I was taught, maybe I need to shift more patients into that group,
Hmm.
right? Um, but again, I think it's harder for you guys for certain. There's so many more different options available now on how to do this. And if you think about it, everyone's saying that their technique does great. So does it even matter at this point, right? Because there's so many different ways. I actually laugh at the fact that everyone's so interested in anterior hip replacements. Yeah, I think anterior hips are great, but anterior, lateral, or posterior, once you get down to the hip, everyone's doing the same operation.
That's
They're
correct.
restoring the hip center, they're restoring leg length and offset, and patients love their hip. No one really cares after 6 weeks
Yeah.
which approach they had done.
Right.
But for knees, I think knees are a much harder operation to try to recreate what patients need or what they had before they had arthritis, and that's a tougher operation.
Right. Correct. And when you talk about um, all the emerging new things, one thing that's come up big time is technology and robotics and navigation. What is your perspective? I know you don't do robotics, and I know you have a philosophy wherein you're basically doing a knee in probably 25 minutes. I have seen you work. So I think that plays a big role. But what's your situation, and are you willing to accept the change of robotics and navigation coming into your practice?
Yeah, so I think it's an important question because robotics is definitely here to stay. I don't think it's going anywhere. I personally don't think the robot is where we think it is, right? I think the robot is a very nice tool to help you fine tune your technique or to precisely perform what you think you're doing.
Mhm.
Okay. One thing that people need to understand is that everyone using the robot today have done thousands of cases manually before they've even used a robot. If you look at your mentors, right, these are people who have switched, but after having been in practice for 15, 18, 25 years.
Yes.
So what they've designed in that time frame is they've designed their tendencies. They've understood what they can manually do. So they're using the robot to fine tune what they've already done. And if they've been cerebral during that time frame, then they know how patients do with their manual techniques. Patients were doing great. Well, now if I change this, right, if I add this element to it, are patients doing better? Are they doing differently? Or like what am I noticing? Uh, I'm absolutely open to technology. I truly right now still personally feel, as you know, very personally having been with me, I feel like our residents and fellows still need to understand fundamentals of how, say, specifically total knee replacements are performed without any technology. Because number one, if you don't know what the numbers mean going into the robot will give you an answer and you're going to hit that target and you don't know if that's the right target for the patient.
Right.
So you need to understand if the information is good or bad going in. Number two, you need to be able to understand when the output is wrong and say that is not the right rotation. This doesn't look right, but you don't have enough iterations of seeing this manually to say to make that decision. The third thing is you need to know what to do in case the robot craps out. And that happens probably once a week in our institution with my other partners. And if
Yeah.
you talk to the residents and the fellows and say, oh, wow, the robot for some reason the trackers weren't working and all of a sudden this was wrong and all of a sudden the power went out and the battery died or whatever it is. And well, then you better be able to finish the operation, right? And I really worry about the people who are doing robotic partial knee replacements because they don't have manual instruments available for one of the systems that's out there. So if it does crap out, you're a little bit in trouble, or now that patient's getting a total knee replacement, which I don't think is the same operation. And then the last thing is, what happens if during your training you become so reliant upon technology and then you end up taking a job somewhere in the United States where you don't know where you're going to take a job as a PGY4,
Mhm.
and now they don't have a contract or they don't have a technology that you're used to using, or they have a contract with a different vendor which doesn't have that robot.
Yeah.
And now you're kind of stuck,
That's
right?
right.
And we've seen patients, or sorry, we've seen trainees who have gotten into practice who have had some real trouble when they don't have the technology they're used to using all the time. So I think you should learn everything.
Mhm.
And I'm trying to right now at Penn, I'm trying to create a system where our PGY twos and threes only do manual surgery. Like
Mhm.
you should not be able to do any robotic type cases until you're a fourth or fifth year, until you understand the fundamentals of what you're doing and what the goals are of total knee replacement. And now you can add in technology to say, how can you dial in a little bit of more varus, a little bit more slope, or change the joint line or change the rotation to understand what those things actually mean, right? Based off of your fundamentals, not just getting thrown into robotics, because most of our residents feel like they're playing a video game and they're like, well, great, you just cut out what's green and like that's the right answer.
Yeah.
I think honestly, one of the things I worry about, Abhishek, like, and I've had this, and you've been in my clinic as well. Like, I see patients who come in and say, listen, the doctor told me that the robot misaligned my knee,
Yeah.
right? That's not correct. At the end of the day, in 2025, patients still want a doctor who's going to care about how well they do and how they feel that if they are not doing well, that the doctor is still fully invested in making sure they have a good outcome and is going to do what they can to get them there. as opposed to, listen, I'm sorry, I used all the technology available to me, and this is what you got, and you don't like it. I'm so sorry. You're one of the small percentage that doesn't love your knee. So I think you have to be careful when we're doing this, and I think there's a lot of pressure on you guys, specifically from industry,
Yeah.
right? And
Yeah.
especially, I know in Mumbai, where you live, there's a lot of pressure with a lot of surgeons who have been there for a long time. How are you going to differentiate yourself? And this kind of comes back to some of the things that we've already discussed about, is that
Yeah.
slowly adopt some of these changes to differentiate yourself so that you understand exactly what you're doing and why you're doing it. Be more deliberate about it
Mhm.
than just changing or making that adjustment or addition into your practice just because you feel like you have to.
Also, with the robot, I think sometimes your alignment philosophy also changes. The way you do things also changes. People go from doing a hybrid technique to doing only bony resections and then trying to balance their knee out. I think there needs to be some amount of control with what's happening out there as far as robots are concerned. But
No
Dr.
question.
Moving from your day-to-day clinical practice to the way you conduct research, and I've seen you do this in your clinics. You have a method of collecting your prompts and your data right at the clinic, and you do that in what, 5 minutes. Along those lines, do you have any specific ideas for surgeons who are busy in their practice to collect their data, to collect their prompts, and have some sort of analytics in their surgical planning as well?
Yeah. So again, we've discussed this, I think, at length with a lot of the other former fellows who have come to visit me. Um, if you look at my system is not very complicated, right? I mean, it's just a matter of thankfully having either a medical student or a resident or a research fellow or someone collecting scores on patients preoperatively. And I think the pre-op score is the most important one. We need a baseline before we do anything.
Yeah.
And right, I've made it very simple. We're using either the Hoosh JR or the Koosh JR for hip and knee, and using the EQ5 as a general quality of life score, general score. I don't think anyone cares what score you use, just get some score, right? Pre-op. And then post-op at their 1 year, 2 year, 3 year, 4 year, we'll get another score. And
Mhm.
that way I can document the score and we can calculate it out in the office. I can put it in their note. I can scan the sheets into their electronic medical record so we have a paper trail of it.
Yeah.
Um, I think all of this requires one thing is just organization, nothing else. None of this stuff is complicated. But this is something that Craig Della Valle actually taught me when I was a fellow. I never learned this as a resident. I learned a lot from him on how to write and how to do research. But his biggest point was that he goes, if you want to do research, it requires you to be organized. That's all. You have to think about it and it has to be at the forefront of your brain. Um, and so it's a matter of creating systems early in your practice that you can perpetuate. I've done this since the first day I started practice. Like I have my own database, which is now close to 7,000 patients. And I had all these entries in there. I even put in when patients have a complication, if whatever it is. That's just my flow, but that's something that I created a habit for 15 years ago.
Yeah.
If I were to ask somebody who's a busy arthroplasty surgeon today to just create this overnight, it is going to be very painful for them and they won't do it, right? There's a huge barrier to entry. So I think when you're early on in your phase, right, other surgeons who are on this webinar that are in their early phase of their career, critical time to do this. You're not busy. You're not doing a billion cases a year. Create a system so that when you get busier, your system can tolerate the busyness and the volume of patients that you're going to see. Um, the thing is, in India also, like it's actually fairly cheap to get assistants to help you with research, right?
Okay.
It's not as much of a barrier as it is here in the US. It's actually fairly expensive to get research assistants. So if that's the case, then just create that system. Have somebody who's available and say, I just need you to be in clinic with me,
Mm.
right? And so as we see these patients, I need you to collect this score and have some place where you have a repository where you can collect that data electronically so you have it. And
Mhm.
then you've got the paper chart, if you will. This all just comes down to systems, nothing else. It doesn't have to be that complicated, but it requires organization.
Right. So basically in your clinic, it just boils down to you having a sheet of paper, having the resident fill it out, and then you enter it into your Excel sheet, and that's about it. That stays with you for
That's
as
it.
long as it does.
Yeah, and I have that Excel sheet backed up to like different sites at Penn onto my hard drive, onto my So I've got multiple different places where I have that in case something goes wrong. But the nice thing is also is that in case we ever get audited by the IRB, I have those sheets scanned into the patient's record, so it's also in their electronic medical record,
Right.
right? So that way, if there's any question, we can always go back and say, "Where's that sheet? These are what the scores were that they filled out that day."
Right. So going back to people like me who are just shifting focus from training to now getting into a career transition, what do you think are the most common mistakes you see people going from training to actually doing things to practice?
Great question. So I think that this is probably twofold. So again, one of the things that, a lot of the trainees will ask this question, they're worried about this, is that you do some complex primary case or complex revision case, and now the next time you do this or see this case, you're going to be on your own.
Yeah.
Your fellowship director is not walking into the OR, and you've got a team around you that doesn't really know you. They hired you a year ago, you finished your fellowship, now you're in a practice, and they're expecting you to just perform and do this case as it's like a normal case or like your senior partner who's done thousands of these. I think that the number one thing that people don't do when they start practice is spend time preoperatively planning. You know how I spend my time on this with our fellows. And this is probably the most important thing I ever learned when I was a fellow. Aaron Rosenberg, who was one of my biggest mentors in fellowship, but he sat down on a Wednesday morning with all of us in our fellowship class and had this conversation. And he said, I'm going to tell you something that 100% of you will hear, 95% of you will listen to, 5% of you will remember, and 1% of you will actually do. And as soon as he started saying that, I was like, I need to be that 1%. What is this guy going to talk about? And he said that he's like, in your first 3 years of practice, you should preoperatively plan every complex primary and revision hip or knee that you do. And I mean a dedicated 4-page, 5-page pre-op plan. And you give this plan to everyone who's involved. If you're in an academic institution, give it to the medical student, the resident, the fellow, give it to your CRNA, your anesthesiologist, your scrub tech, your circulating nurse, and every rep that's going to be in the room. This should be a game plan roadmap of what you plan to do and identify the parts of the case where you think things could go sideways, where you might need 2 or 3 different things available. And he goes, trust me, when the circulating nurse sees this in the beginning, they'll say, oh my God, what is all this stuff? But they will be so much happier that they have what you need when you says, please have this available, but don't open it, which means keep it outside of the room. And if something goes wrong and now you have to do an osteotomy or something and you need some different piece of equipment, that nurse is going outside the room as opposed to trying to find it in room 4 or room 7. Where did they leave it yesterday? Is it downstairs in the basement while the patient's hip is open?
Mhm.
So by doing that exercise, you've basically played the game before you play the game, right? No one is watching. India's playing Pakistan in the World Cricket Finals. Like, there's no chance they're not watching Pakistan's like game film like weeks in advance in preparation for that game. They're not going to just show up and say, let's see what happens,
Yeah.
right? They have a plan that they're going to execute on the field. And then if that execution is not working well, they need to pivot and they need to fine tune their approach in order to win the game. That's kind of what we do for every single case.
Yeah.
So I now, for my first 3 years, I have over 500 plans on my computer of cases that I did. The big thing is, and this is the question you're kind of getting at, is when you start practice, you're going from seeing to doing now, and you're responsible for this. The worst part is you can come into a practice, and it may be a little bit different in India, but definitely in the US, you come into practice, you have that big complex revision case. It's the worst when you think, oh, it's going to take me 2 hours, and now it takes you 7
Yeah.
because the whole staff around you is looking and say, oh my God, Dr. Nighot is operating again tomorrow, so I'm actually going to take tomorrow off. Like, I don't want to be there,
Yeah.
right? You want to under promise and over deliver, right? So, which means you say, oh my God, I'm booking one case today, 7 hours.
Mhm.
But when you're done at 2.5 and you're closing, they're going to be like, oh my God, this guy is amazing, right? This guy is so great.
Yeah.
But if you've done all your planning ahead of time, it really helps minimize that time. So now I have the luxury of having fellows, so I have them do this plan. And as you know, the fellows will send me a plan by Sunday morning, and I will send back right? 30 questions of things to think about. We just did a very complex case on a 23-year-old girl who had 7 hip revisions before. We
Mhm.
just revised her hip last Thursday. She had a well-fixed cylindrically coated stem that was being notched by
Mhm.
her dual mobility cup. And taking that stem out on also, she's BMI 50, but
Mhm.
taking that stem out, I knew this was going to be a very long case.
Yeah.
And I booked it on just a Thursday single case, not my regular Tuesday, Wednesday OR. But I told the OR, I said, I was like, this is going to take us 4 hours plus to get this stem out. So
Mhm.
they were prepared, but it's great when we're closing at 2 hours and 20 minutes.
Yeah.
But I had the fellow go through every single step of what could possibly go wrong. And then we encountered something that we had not encountered or thought of. And I'm like, huh. And you can imagine if if you haven't gone through that process and then you encounter something by that point, your brain is like pudding and you can't even think anymore and you're exhausted physically, mentally, you're not thinking well. And everyone in the room is looking at you. They're not looking at anybody else,
Yeah.
right? So you want to get yourself prepared as much as you can. That is probably the best piece of advice anyone has ever given me. If you're going to go into a career doing complex cases, right? Um, but yeah, by far, I cannot stress enough. And the more you do that process, the faster you get into those cases. And all of a sudden, like the whole team came in Thursday to help me out. And they're
Mhm.
like, man, this must be something big if it's going to take you 4.5 hours, right? Or you're planning for it to be that long. So get into that. I think it's important to get into that sort of that system and that mindset early on, and then you can perpetuate that going forward.
But Dr. Sheth, there comes a question, how much training is good? When does one stop training and start practicing?
Um, that's a very good question. So I think number one, I don't think your training ever stops, right? I think once you actually have learned the language of what we do, I think that's when your training truly begins. I mean, you know that I just changed my entire revision hip exposure 2 years ago. That's after 14 years in practice, after having done thousands of cases. And I'm like, oh my God, this has changed my whole practice. I think I know the system in India is a little bit different on
Mhm.
how you guys train. And then you guys go through certain steps and you're doing a lot more observership for some portions of your training. Um, at some point, you have to understand that you know the fundamentals of what you're doing.
Mhm.
The rest of this, and this is, I think, why they call it the practice of medicine, not that you're practicing on patients, but you're fine-tuning your technique, your approach. And I think that if I think about someone like you personally, like you're absolutely ready to start doing all of this on your own. You just need to pick out those cases and you have good mentors and people that you can reach out to at any time to help you in that pre-op planning phase, right?
Yep.
Play that game before you get into the OR so that you can go execute your plan. You also have access to senior partners who are around that can help you,
Yep.
right? This is not a time for ego. At the end of the day, the only ego that should be driving you is making sure that the patient on the table gets the best care possible, period. Right? This is not a personal ego thing. Um, I think once you have the requisite steps that you've gone through, then you have to kind of like you have to get off the bench and start playing the game,
Mhm.
right? But
Yep.
I think, the reason I say that this training is never done is because when you do that first case, or if it's your 10th case, you have to critically look at that case, look at the outcome, look at the x-ray, look at every decision you've made,
Mhm.
pre-op, intra-op, post-op, and be critical of what you've done, right? Measure every single piece of bone that you resect out so you get a sense to say, wow, this is what 12 millimeters looks like. This is what 15 millimeters looks like, right? So you have an idea over time, like what you're actually doing. And all of that stuff starts getting less cumbersome and you become much faster and reproducible at what you're doing because you've done it so many times, right? Or you've spent the time early on when you had time to measure all those things. Um, yeah, I mean, at some point you kind of have to jump off and say it's time to start doing this.
Right.
You and I have had long discussions, right? Because I think in your stage, it's also easy to go and do so many observerships and learn so many different things, but then you come back and none of those things have been incorporated because it's too overwhelming. Change
Yes.
one thing at one time, but you need to just start and then you can start doing some work and then figure out what you want to spend time on. that you want to really change because you think it's going to be a bigger impact for your patients?
That makes a lot of sense.
Yeah.
Akshay, going back to knee arthroplasty, you see a
Mm.
lot of implant designs coming up, especially in India. We've now got the cruciate retainings, the deep dish, the medial pivot knees. You've got so many things, and somewhere your implant designs are sort of directing the way you do your knees. How do you approach this problem? And do you stick to one implant or are you open to experimenting with newer implants?
A great question, because again, it's along the lines of changes in alternative alignment strategies, and right, we're adding all of these things together, and there's all these different combinations you can come up with.
Yeah.
I've been a CR guy for my whole career, and it was up in 2020, 5 years ago, that I switched over to using a medial congruent type plastic.
Mhm.
And the only reason I switched was I said, I was like, people are using this. I was like, this is becoming the most popular type of implant in the United States. I'm like, I wonder what is the benefit. I looked into it, I read about it and said, okay, they're trying to recreate kinematics of the knee a little bit more, where
Yeah.
there's a little bit more stability on the medial side of the knee and it's a little bit freer on the lateral side. Maybe there's a little bit better rollback. Let me take a look at this. Then I switched without changing any other variables. Same incisions, same approach, same balancing strategy, still doing CR and putting in a medial congruent plastic. And all I noticed was that 2 weeks, people were coming in with better reciprocal stair climbing than patients who had CR knees. Not that my CR knees were unhappy. This actually led to us looking at 500 consecutive CR knees versus 500 consecutive MC knees. And we found zero difference, which we're publishing that data right now. Um, so that just tells me that if you balance your knee right, regardless of what bearing surface you're using, it doesn't really make a difference, right? Balance the knee properly. I think with all these alignment strategies and all these things that are coming out technologically, I think the baseline thing that's really important is you have balanced gaps. That's what people probably care about the most.
Yeah.
However you get there is up to you, right? And whatever you can do reproducibly, whatever technology you want to use, fine, whatever bearing surface you want to use. But at the end of the day, you need to have balanced gaps. But understand though, I have a very, very inherent bias, and it's someone my mom, who has her knee in there for 33 years,
Yes.
right? She has a total knee in there that has bad technology, has three sizes. The extra small size is too small for my mom because she's tiny, right? She has bad cement technique. She's got bad plastic that was probably gamma radiated in air. And it's literally a third of a century. And if I work hard, I can probably dislocate her knee in her living room because her knee is grossly unstable, but she loves her knee.
Yeah.
So I don't know what target we're trying to get to, because all of the things that you're talking about, different bearing surfaces, alignment strategies, technologies, all of these things incorporated may not even get that result,
Yeah.
right? And there's so many other factors that go into why my mom is doing well, right? And over years, over literally a third of a century, her knee has changed because I'm sure, right, Tom Skulko, who put her knee in 1993, did not put it in this loose,
Yeah.
right? But as she has aged, her ligaments have stretched out and right, compliance of her tissues have changed, but she's gotten used to this and this is what it is,
Yeah.
right? So I don't know the right answer. I think again, like if you use any of these new bearing surfaces, you just have to make a change and then look. And that's why I wanted to look specifically and say, give me a few years. I'm noticing anecdotally people are saying this at 2 weeks, but is this better, worse? I have no idea. Is their range of motion better? Is my manipulation rate worse? Are people like, am I revising more of these knees compared to my CR knees? And I'm glad that the change or the difference was really negligible, no difference.
Right.
So I think if you balance it properly, I don't think it makes a difference what bearing surface you use.
Right. Dr. Shet, talking about balance, I know you enjoy an excellent work-life balance. What are your tips for somebody who is a busy arthroplasty surgeon such as yourself to balance work, life, and I know you will say this is the wrong word to use, but also add on to a lot of commitments such as this one into your plate without having
Yeah.
to think about a lot of variables. How do you do this?
Yeah. I mean, this is, as you know, Abhishek, you and I have had probably more conversations about this than I've had with most other fellows. And I think that most of the people that come visit me probably pick up more on this aspect of my approach to things more so than what I can even do in the operating room or in the office. Um, and you're right. I think the work-life balance term, I think, is a little bit misrepresented in the sense that to me, I don't think people should be balancing one at the expense of the other. If you have the option right now to balance life as opposed to working more, people are going to always choose life over work. Our mentors, right? Mentors of mine who are now in their 80s and 90s, those guys probably balanced it differently where they chose work over life, right? And they had partners or they had families that tolerated this or didn't tolerate this and they ran into trouble somehow. And I think today that is not going to work well. So I think the real trick is balancing life while you're balancing work, not one at the expense of the other. My thought is that you want to have a system in place so that when you're working, and I'm not worrying about other stuff. But then when I'm home, I am focused on home, and I'm not just physically home, but mentally present and not thinking about something else about work. And so I try to minimize residual between the two. And I think that's the real trick. And as you know, Abhishek, like, I mean, again, we've spent a long time talking about a lot of this, but the system I have in place now is based off of years of continually working at this. And I started some of these things early on when I was younger, when I wasn't married. I didn't even have to be home at 7 p.m. for dinner. I could eat at 10 o'clock at night. No one cared. But let me start getting comfortable with that systems to say, hey, look, I'm done with clinic at 4. I'm not going to go home till 7, which means I'm going to sit in my office for 2.5 hours and get work done that I would normally do at home. So I'm going to go home at 7. And even if I wasn't married at that time and I didn't have to be home, I got into that habit of coming home at that point.
Yeah.
So now with my wife, like she knows that dinner is going to be 7 p.m. on Monday night. And even if we finish clinic at 5:15, I still spend an hour and a half, right, to do work or to get things done or make sure my inbox is cleaned down and is zero so that when I go home, I can spend 4 hours of uninterrupted time at home, focused at home, not worrying about anything, not on my phone, checking my email every 30 seconds, right? I'm not worried about any of that stuff. If there's an emergency, someone will call me and I will answer the phone if it's a resident or my chairman, if there's something I have to do. But other than that, I'm not linked to work, then I'm at home. Um, I think there's definitely things that you can do early in your career when you have more time,
Mhm.
right? What happens is I think people will basically mold to the time that they have, and then they become a little bit more inefficient in the beginning because they have so much more time, they have less responsibilities, and as responsibilities keep piling on, and especially if you want to have an academic career and where you don't say no to things early on,
Yes.
your system's not ready to tolerate all this stuff. So then you just perpetuate bad habits,
Yeah.
right? And you don't want to be the person who now looks and says, wow, I have 160,000 emails that I've never checked, but you're responsible for this and you're the president of that. And people are asking you to respond and they're like, oh my God, this guy's not even getting back to me, right? So it's a matter of coming up with small things that you can change to create a system. And I cannot stress enough, it's probably the biggest thing I teach all of our trainees is that look at your system so that I can spend time on a Friday morning and my family's not upset with me because I set it up as a time where it works for you guys. I can spend an hour, right? And while my wife is getting dressed and getting set for the day, and we're gonna go see my parents in a little bit, like they're doing stuff while I'm doing this for to spend time with you for an hour. So it's not as cumbersome. And the thing is that I don't really request that much time off from my family for these kind of things. But they know if I'm going to do this, it's because it's important to me. And the other thing for me, Abhishek, is like traveling time is work time. If I'm traveling for work, like I'm working, I'm not watching movies on the airplane. Like if I'm coming to India and it's a short trip, I'm getting work done or I'm resting so that when I come back, I'm not like, oh my God, I have so much stuff to do because I was away in India for like 4 days. So I'm just much more deliberate about what my time is uh is deliberately dedicated for on my calendar. So I know exactly what I'm supposed to be doing at that time. And my threshold, as you know, this is 90% of the time I should be doing what I said I was going to be doing on my calendar,
Yes.
right? The 10% of time is something I'm really tired or wow, that case took longer than I thought. And like I was going to do this, but I'm physically not in the right space. I'm mentally not in the right space. I don't have the right attention or energy right now, so that the amount of time it takes me to do this task is gonna be way longer than I thought. I'm moving into a different part of my calendar because this is not the right time to do it. Um, and
I
so
think
it's those kind of little things. Go ahead. Sorry.
most people would have done some sort of time blocking, but where the game changes is where you keep your threshold. If you're somebody who's doing it 90% of the times, then you've already killed it in your calendar and you're sort of there and you're in place. But for people, it's really difficult to anticipate that. And I think that is a major hurdle because time blocking is rather easy, but then to follow it up probably would be the most difficult bit.
I think the one step before that, Abhishek, is that most people don't realize how long it takes them to do a specific task.
Mhm.
So I think I've shown you my list, right, that I go through every 6 months, and I break everything up into 15-minute increments. So 15 minutes, 30 minutes, 45 minutes, an hour, and then it's an hour and a half, 2 hours, or 3 hours. I look at specific tasks that I can finish in a specific amount of time. So, for example, if you and I are writing a paper together and you send me the first draft of a paper that we're writing, I will block 90 minutes on my calendar to fully focus on that draft. If you've done a really good job, I might be done with this, reading it, and be like in 20 minutes and say, wow, Abhishek, this is really good. Very few changes. I would change a little bit of this and that. And then what happened? I just made up an hour of time right on my calendar.
Yeah.
Versus if I go through this thing and I'm saying, wow, you really missed this, and I have to spend a lot of time, but at least I have time, energy, and attention dedicated to focusing on your draft. Then I can spend the hour and a half, do what I need to do, and then they send you an email back and say, hey, look, I think we need to change this. This is how I would do this. Send me another draft, right? But I will say, send me another draft. And whenever that draft comes in, I will look on my calendar and say, I need another 90 minutes of time to focus on this draft,
Mhm.
right? So then when I respond to your email and say, hey, I got your draft, thank you so much. I'm going to get this back to you in 72 hours because I've put an hour and a half on my calendar tomorrow or 2 days from now to focus on your paper. Um, so the thing is that the first step, I think, for anyone who's listening to this is trying to figure out what tasks you do on a normal basis and how long do you think it takes you to do that? And whatever you think it takes you, double or triple it until you've done it so many times that you know you can reproducibly do it in that amount of time. So that allows me, Abhishek, to not ever start something in a time slot that is shorter than how long it should take me. The other thing that's critical to time management is you might block out the time. You may even figure out how long it takes you, but that's assuming you have the right amount of attention and energy at that specific time. And if you don't, you have to listen to that and say, this is not the right time for me. If I'm on a flight somewhere and I'm going across multiple time zones, and I may say I want to work from 10 p.m. to 1 a.m., like on my time to work on this, but I'm exhausted, I'm tired, and I'm not really focused, then I'm moving it to a different part of my calendar. Like right now is not the time to do this because I'm tired, I'm not focused. It's going to take me longer. I'm not doing a very good job at this. Right. So let me rest right now so that I can maybe do this tomorrow when I arrive where I'm going to be and be able to do it properly. Um, those are some of those are the very sort of, I think, fine-tuning tricks that are important because you're right. I think people are good about trying to block things off, but then they don't get the stuff done during that time. And now it just gets on a to-do list, and that list gets longer and longer as
Yeah.
things become more urgent. And now it's number 15 on your list and you never got to it.
Also, it's important to not have a to-do list become a wish list. I think,
Yeah, exactly. Yeah.
and
I mean, I don't have a to-do list. My to-do list is my calendar and my email.
yeah,
That's it. So if it's on there, it'll get done. If it's not on there, it won't get done. So I don't have a list, right? I don't have something with a list of things that I need to check off
yeah.
because it doesn't really matter. This is my list. And that again, my moving, and I think probably one of the things that the fellows and stuff that actually spend time with me notice is the fact that I will move things very quickly from one side to another if I'm not going to get it done,
Mm.
right? So
Yeah.
if that's the case, then let me move this so I have a dedicated time on my calendar again where I need to focus on this. The other thing that Abhishek people ask me a lot about is so forget travel time, but what happens if it's the weekend? How do I use my weekends? And I think the problem is it's so easy to be on your phone. Everyone is connected every second of the day, right? So you could be hanging out doing whatever, and now all of a sudden your phone pings and oh my God, what is this? I got to deal with this now. On the weekends, if I'm home, I typically get up at like 6 in the morning, right? And one of those days I'll go to the gym or I'll do something early in the morning for an hour by myself. But then from 6 to 9 in the morning, I will do work every weekend. So
Mhm.
again, while my wife is kind of joining the real world and has her coffee and watches the news and gets dressed, that's going to be a 2 to 3 hour time frame. During that time, I'm focused. I get my work done, but then come 9 o'clock in the morning, I'm fully free for the rest of the day.
Yeah.
So I don't feel like I've professionally not been productive. I also don't feel that like there's stuff that's lingering in my mind that I still need to do because it's already done. And then if my in-laws say, "Hey, we want to go watch the Penn State football game," like, great, I'm free. Like, let's go. Let's go hang out. Like, I'm not worried about work that I'm not going to get done because next morning I'm going to get up again early. I'm going to get that work done in the morning and then have the full rest of the day. That Sunday morning, 6 to 9 in the morning, I also pre-plan for the week. So
Mhm.
that first 30 minutes, I'm actually out looking for the rest of the week to say, what do I have coming up this week that I need to focus on?
Right.
Because then, say for example, I have something that I need to do. Say I'm reading one of your manuscripts. Maybe we're on draft number 7.
Hmm.
And for that one, I only blocked off 30 minutes and I read draft 7 and say, wow, this is really tight. Like we're done almost with this. Couple of things to change, maybe one more image, this, that, and say that takes me 10 minutes to read, 15 minutes. I send that off to you and now say maybe I made up another 15 minutes, maybe I get something else done. Say I made up an hour. I'm going to look forward during the week and say, what else did I have blocked off that I need an hour to do? I'm going to move that forward into Sunday morning slot because I just picked up an hour during the week,
Right.
right?
Yeah.
So by having that 30 minutes early morning Sunday to look out for the next 5, 6 days is really helpful to make sure I can fine tune my schedule even more.
Right. Dr. Sheth, you also have a specific protocol for your clinics wherein you have a time slot for your old patients versus the new patients that you see in. Can
Mhm.
you explain a bit about that?
Yeah, no, that's important. Our current fellow right now, Kathleen and I were just talking about this last week because she covered clinic with me for the first time on Friday last week. And so typically on a Monday, I will see 50 to 60 patients, as you know.
Yeah.
And then on Fridays, when I have a half day clinic, but in a half day, I'll see maybe 35, maybe 40 patients, maybe a little less, but 35 patients. So what I do now is basically new patients. Everyone has a 10-minute slot. New patients are scheduled for the the top of the hour at 0 minutes and at 30 minutes. So every hour I'll see 6 patients. Um, and I will have the first patient will be a new patient, and then the middle 2 patients between the 0 and 30 time will be a return patient, an injection, an annual follow-up, or a post-op patient. And so that way I can have the resident or fellow go see a new patient, spend some time with them, right? Get their story. I can knock out the post-op patient. I can knock out a patient who's here for an annual visit, someone who's here for a quick injection, right?
Mhm.
Get that rolling so that once the resident fellow is out to present to me for that next patient, then I can go in and spend some time with that patient, but I know kind of what to do or what I'm thinking about. So that allows me to see about 16 to 18 new patients in a day. The other thing that's important is say you have a post-op patient that has a problem. Say you have a patient that comes in and they call in and say, hey, I've got a knee that's draining and I'm a little worried about it. Well, I need to see that patient. So that's not going to go into a post-op slot. That may go into a new patient slot,
Yeah.
right? So that my assistant knows that to say, hey, I'm going to put them in, or they'll come in at the end of clinic or something like that.
Hmm.
Um, because that's going to take a little bit more time.
Yeah.
Also, my assistant is so good that she knows when return patients are coming in, say they had their right hip done, they're doing great from their right hip, but now they need a left hip. That's essentially like another new patient visit because I'm seeing them for a different problem.
Yeah.
Problem is you get all those patients lined up. If you have 4 return patient visits in an hour plus 2 new patients, and now everyone needs surgery, that's going to really back you up.
Yeah.
So critical thing is actually working with my team, understanding how the flow should be, and having someone like Yen, who's my assistant, who's phenomenal. She's at a level where she can bird dog and look at the entire calendar and look at people and say, "Yep, hey, this is a patient that's a chronic pain patient, someone who's going to take more time. They have a ton of questions. They need a lot more hand holding. I'm going to give them a new patient slot as
Mhm.
opposed to just put them in the middle of like, hey, they're a return patient visit. Other thing, Abhishek, that I'm starting to do now is those patients who are some of the younger patients, right? The 14-year-old that has Down syndrome that needs a total hip. Those patients are now getting booked for 30-minute slots.
Mhm.
So I'm now at 10 o'clock in the morning opening up a dummy slot for 30 minutes, which gives me some time if I'm backed up a little bit in the morning, which typically happens because people are double or triple booked or you're signing up a lot of surgeries. Or it'll give it for a PEDS patient or someone who's had multiple revisions, chronic, something weird. We'll have some couple of 30-minute slots in the day. So either I'm going to use that to catch up or it's going to use that to like see someone who's going to require more time.
Right.
But yeah, that's these are things that have taken me years to kind of figure out. And again, it's important if you start thinking about this stuff early on when you're not busy, create those systems so that when you do get busy, you can fine tune it to adjust to whatever you're seeing because it might be different that what you're seeing versus what I'm seeing.
Right. Dr. Sheth, we are at the end of our interview. I just want to ask you one last question, which
Yeah.
is you've been doing this for quite some time. What excites you about arthroplasty and what brings you back to the game time and again?
Yeah, that's a great question, and it's a good, I think, closing question. I had to do some soul searching probably about 3, 4 years ago, and trying to figure out, exactly what excites me or what keeps me driven to keep doing what I'm doing. And I realized that the two things that I am probably the most passionate about is having the opportunity to teach, right, at every level, whether it's a med student, it's a resident, it's a fellow, international visiting fellows like yourself. That is what keeps me going. And number two is being able to do complex revision cases that most people will not do, or either they don't have the team to be able to do it. But those are the cases that I spend more time thinking about. And if I was in private practice, it would be fun for 2 weeks just doing primary after primary after primary. I think I would get bored. Um, so those are the two things that I think are the most important to me. I truly believe, though, Abhishek, like in the last 5 years, we've had what, 15, 16 fellows that have come over from India. And I think the fact that I'm so fortunate to have the opportunity to come to India as often as I do, spending time with you guys, watching the next generation, having the ability to have some impact on helping you guys create your practices. And I think truly the best part for me is interfacing with anyone who's going to be a part of this is hopefully having an impact on a patient I'm never going to meet through you, right? Through some other fellow, through some other resident. And I get more excited about how well you guys do in practice and how well you take care of patients more so than anything that I can do myself. And that's truly, I think, what drives me. At the end of the day, it's not about money, it's not about titles, it's about doing what's right and taking care of our fellow man because there's a lot of people on this planet that need help.
Yeah.
And we have this incredible opportunity and ability to help people. And I think we forget the one word, which is privilege. We have a privilege to help someone. It's not
Right.
because you get paid for it. I think people still care and have compassion, but it's privilege. And so for me to be able to interface with people like you and have so many fellows and have so many people who spend time in this field, I mean, that's a huge privilege. That's what drives me.
Dr. Sheth, quick follow-up question. What do you think about the arthroplasty practice in India and with the emerging arthroplasty business that's coming on to India? What do you think is the near future?
I the volume of arthroplasty in India is on a tear, right? I'm trying to think back in 2015 when I heard the number of 150,000 joint replacements being done in India, right? And now we're probably close to like 500,000 joint replacements being done all throughout India.
Yes.
So the volume of patients that are going to need arthroplasty is continuing to rise. There's a lot of schemes that are being given by the government, right, and different state level governments to help patients get access to care that they didn't have access to care from before. There's a lot of centers that are doing a tremendous amount of volume of surgeries, but I do think that in accordance with that, there's going to be a huge rise in revision burden.
Yeah.
There's no just the way it is. I mean, in the United States, we're doing over 1.2 million joint replacements a year for a population that's one-fourth of India.
Yes.
And the revision burden is still a big deal, right, in certain centers.
Yes.
So I think that the need for arthroplasty is always going to be there. I think the need for learning complex revision care is going to be incredibly important. But also, I think your primary cases are like revisions, like they're complex primaries, right? You've been in my clinic. It's embarrassing some of the people that come in for knee arthroplasty or hip arthroplasty and barely have any arthritis and they're in a wheelchair.
Yeah.
um, I think that it's going to be very important. I think one of the key things that's going to have to happen is industry is going to have to really take on some of this burden of making sure that people are educated properly to do what they need to do to implant their implants.
Yes.
Because if industry continues the way that it does in general around the globe, where they're just looking to sell an implant, I understand that you're evaluated by the metrics of sales. But if you're selling implants to surgeons who are not putting them in properly and your implants fail early, it may have nothing to do with the implant, but it may be surgical technique, maybe poor indications, maybe whatever, it may be other factors. I think they're going to have to take a bigger role of making sure that surgeons are trained properly to be able to put their implants in the right place, in the right position, with the right balance. It's a big burden. There's no question. And the burden in India is not going away anytime soon. You have 1.4 billion people,
Yeah.
right? That's 2.8 billion knees that need to be replaced at some point.
Yeah, but we also now have a big arthroplasty community, and thanks to people like you, hopefully through Arthroplasty TV, we are able to guide them in a direction where they can impact more lives and do a good arthroplasty business out of the medicine.
Absolutely. Very important.
All right, Dr. Sheth, thank you so much for.
Thank you, Abhishek. Thanks for this opportunity and a great conversation and some really important points I think we discussed over the last hour. And I think this is a great thing that you're working on. I think this is going to be very helpful for a lot of the surgeons who are in the same situation that you're in, right? All throughout India, that are going to face the same challenges and things that they need to think about in order to preemptively prepare themselves so that they can have a nice, long, and fruitful career in arthroplasty.
Thank you, Dr. Sheth. This was very insightful and hoping to have more of you on Arthroplasty TV in the near future. Thank
Great.
you.
Thank you, Abhishek. Take care. Have a great rest of